Hey there, and welcome to a deep dive specifically crafted for you, pulling insights directly from your pressure ulcer revision materials. Our mission today is to really consolidate the crucial information on this important topic.
Yeah, cutting through the noise to help you nail it for the MSRA exam and, for your clinical practice too.
Absolutely. Pressure ulcers are incredibly common, aren't they? And knowing the ins and outs isn't just vital for scoring points.
No, it's fundamental. It's about providing good care, especially for vulnerable patients. We're going to extract those high-yield nuggets and hopefully make them stick.
Great. So let's just jump right in. When we talk about pressure ulcers, sometimes called bedsores or pressure sores, what exactly are they?
Okay, so at its heart, a pressure ulcer is localized damage. It's damage to the skin and the tissue right underneath it.
Localized, so not spreading everywhere.
Exactly. It's focused damage in a specific spot. Right. And the key triggers are prolonged pressure or friction. When you have that sustained pressure on one area, it basically squeezes the tiny blood vessels, the capillaries, and reduces blood flow.
Ah, okay.
And that cuts off the supply of oxygen and nutrients to that tissue. We call that ischemia.
Ischemia, right.
And if that pressure isn't relieved, well, the cells die. That leads to tissue necrosis and ultimately the ulcer forming.
Ah, so it's almost like putting a really heavy weight on a hose and cutting off the water supply.
That's a great analogy, actually.
Yeah.
The tissue is essentially being starved.
Makes sense.
And while, technically anyone could get one, it's most commonly seen in people who have difficulty moving. People confined to a bed or a chair for long periods.
And the material you shared emphasizes pressure, friction, and also moisture as the main culprits.
Yes, those three are key. Pressure, friction, and moisture.
And treating these, they must be a significant burden on healthcare systems.
Oh, without a doubt. Managing pressure damage is not only costly, but the expense really skyrockets with the severity of the ulcer. It's a major public health issue and a big financial one, too.
Right. So prevention is clearly the goal.
Yeah.
Moving from the what to the why. What are the deeper causes, the etiology, beyond just that physical pressure?
Well, as we said, the primary cause is that pressure being higher than the capillary filling pressure. So it reduces blood flow. But, yeah, other factors contribute significantly.
How so?
Think of them as creating the environment where that pressure becomes much more damaging.
Okay, what kind of factors are we talking about here?
Things like friction, skin rubbing against a surface.
Yeah.
And shear forces.
Shear, what's that exactly?
That's when layers of skin sort of slide against each other. Often happens when someone slumps or slides down in a bed or chair. It stretches and damages the underlying tissues and vessels.
Got it.
Then there's moisture, usually from incontinence or even just sweat. It softens the skin, makes it more fragile. Poor nutrition weakens the tissue itself.
Okay.
Impaired sensation is a big one, too.
Yeah.
If someone can't feel the discomfort or pressure that would normally make them shift position.
They won't move to relieve it.
Exactly. And then impaired circulation, maybe due to other conditions, means the tissues are already getting less blood flow to begin with.
So pressure is the main trigger, but these other factors are like accelerants.
Accelerants,
That's
spot on. They make everything worse.
Mm-hmm.
This leads naturally into who is most vulnerable, the risk factors. And the list seems quite extensive.
It really is. And identifying these is just critical for prevention, isn't it? Maybe we can group them a bit.
Good idea. Let's think about mobility first. So anyone with immobility, whether that's from bed rest, being wheelchair bound, maybe limb paralysis, a hip fracture.
Or conditions that limit activity.
Right, like severe heart failure or, say, Alzheimer's disease where mobility is reduced.
Okay, so anyone who can't easily shift their own weight, that makes sense. What's next?
Then consider factors related to skin and sensation. Things like advanced age skin naturally gets thinner, less elastic. Incontinence, which causes that moisture damage we mentioned.
Right.
Poor hygiene can contribute. Sensory impairment, like you see in diabetes or certain neurological conditions. Even things like lower limb edema can make the skin more vulnerable.
So the skin itself is compromised, or the person just can't feel the warning signs.
Precisely. And finally, think about underlying health. Malnutrition and dehydration are huge. Chronic medical conditions like diabetes, vascular disease, COPD, even malignancy.
Wow, quite a list.
And smoking, too, it significantly impairs healing and circulation. Oh, and recent weight loss is also mentioned as a major red flag.
That grouping definitely helps make a long list more manageable. Okay, quick scenario for you. Picture an elderly patient, say 80 years old, with type 2 diabetes. They've had a fall, limited mobility now, maybe struggles a bit with incontinence, Based on that, where would you immediately put them on a risk scale?
Oh, definitely high to very high risk. Straight away, you've hit multiple categories. Their age, limited mobility, chronic condition with diabetes, potentially sensory issues, and incontinence. They tick a lot of boxes for vulnerability.
Okay. Now, you sometimes hear about risk assessment tools like Norton, Braden, or Waterlow. How do they fit in?
Yeah, they're widely used. They're basically structured ways to systematically evaluate a patient's risk based on many of these factors we've just discussed.
So they give you a score.
They do.
Yeah.
But it's interesting, the source material points out there's actually limited strong evidence that just using these tools actively reduces the number of pressure ulcers.
Oh, really?
Yeah. They're helpful for identifying who is at risk, guiding you on who needs preventative measures. But they don't replace your clinical judgment, and they certainly don't do the prevention themselves. We'll touch on the Waterloo score specifically later under investigations.
That's a really important distinction. They help you spot the risk, not eliminate it. Okay, let's dig a bit deeper into the mechanism of injury, right down at the cellular level. What's the pathophysiology?
It really circles back to that hose analogy we used, when the external pressure is greater than the pressure inside those tiny capillaries.
It squashes them.
It mechanically obstructs the blood flow, and that leads to localized tissue ischemia, that lack of oxygen and nutrients we talked about.
Like the cells are basically suffocating.
In a way, yes. Without oxygen, the cells just can't function properly. Waste products build up. And if it goes on too long, you get irreversible cellular injury, leading to tissue death necrosis.
And can other factors worsen this process once it's kind of started?
Oh, absolutely. Inflammation, which is the body's response to the injury, can actually exacerbate the damage initially.
Okay.
And of course, if the ulcer gets infected, that introduces a whole new level of tissue destruction and potential systemic risk. Plus, underlying factors that impair wound healing, like poor nutrition or maybe uncontrolled diabetes, mean the body struggles to repair the damage even once the pressure is off.
Right, that makes sense. Okay, before we get further into managing and preventing these, what else might present with similar skin changes? Things we need to distinguish a pressure ulcer from. What are the differential diagnoses?
Yeah, this is a crucial step clinically. Not every red patch or sore is a pressure ulcer, right? Important differentials include things like dermatitis, just inflammation of the skin.
Yeah, okay.
Then you've got venous ulcers, often related to poor vein function, arterial ulcers, due to poor artery function, diabetic ulcers linked to complications of diabetes, and even simple traumatic wounds, from a specific knock or injury.
Okay, let's say in an exam scenario, or even clinically, how might you quickly differentiate between, say, an arterial ulcer and a venous ulcer?
Location is often a huge clue. Arterial ulcers are typically found further down, maybe on the feet, toes, or bony points like the ankle, and they tend to be really painful. The surrounding skin might look pale, shiny, maybe cool to the touch.
Right, painful and pale.
Whereas venous ulcers are usually located in the gaiter area, sort of lower leg, around the ankle. They're often less painful, and you frequently see signs of venous insufficiency like swelling, edema, and maybe brownish discoloration of the surrounding skin.
Ah, okay. Gaiter area, less pain, swelling.
Exactly. And diabetic ulcers often appear on the soles of the feet or toes, particularly over pressure points. They can sometimes be quite deep, almost punched out, and crucially might be painless because of nerve damage, neuropathy. So thinking about location, pain, and the surrounding skin appearance is key.
That's really helpful for sorting them out. So how common are pressure ulcers in the real world? Give us a sense of the epidemiology.
Unfortunately, they are quite common, especially in healthcare settings. The prevalence figures cited range anywhere from, say, 4% up to 20%, depending heavily on the setting and the patient group you're looking at.
And higher in certain places.
Oh, yes. As you'd expect, given the risk factors, the prevalence is significantly higher in places like long-term care facilities and intensive care units, where patients have limited mobility and often multiple other health problems. Older adults and those with chronic illnesses are definitely the most affected populations.
So in those vulnerable groups, the numbers really climb. Right, let's talk about what they actually look like and how we categorize their severity. What are the clinical features, and how do we use classification systems?
Okay, so we use staging systems to describe the depth of the tissue damage. The European Pressure Ulcer Advisory Panel, or EPAP system, is very widely used. It breaks it down into grades or stages based on what you can see.
Okay, grade 1.
Grade 1. This is your earliest warning sign. The key thing here is the skin is intact, but you see what's called non-blanchable erythema.
Non-blanchable, meaning?
Meaning redness that doesn't turn white or pale when you press it gently with your finger. In darker skin tones, it might look like persistent discoloration, maybe purplish or bluish. The area might also feel warmer or cooler or firmer or softer than the surrounding tissue. It's superficial, but it tells you there's underlying tissue stress.
So intact skin, but a stubborn red patch over, say, a bony area?
Exactly. That's potentially a grade 1. Got to investigate.
Okay, grade 2.
Grade 2. Here you've got partial thickness skin loss. It involves the epidermis, the top layer, and maybe part of the dermis underneath. It might look like a shallow open ulcer, often with a reddish-pink wound bed, or it could present as an intact or ruptured serum-filled blister.
A shallow sore or maybe a blister?
Yes, those are the key things for grade 2. You don't see any fat or deeper tissue exposed.
Got it, grade 3.
Grade 3. Now we're talking full-thickness skin loss. This extends down through the dermis into the subcutaneous tissue, the fatty layer. You might actually see some yellow fatty tissue exposed, but, and this is key, muscle, bone, or tendon are not visible. You might see some slough that's kind of yellowy, stringy dead tissue, or maybe Escher, which is darker, hard dead tissue, but you can still tell the depth only goes down to the fat.
Okay, getting deeper now into the fat layer, but no bone or muscle showing.
Right. That's grade 3.
Then grade 4.
Grade 4. This is the most severe stage. It involves full-thickness tissue loss, where you have exposed bone, tendon, muscle, or maybe other supporting structures like fascia. Slough or Escher might be present, and you often see undermining or tunneling, where the tissue damage extends sideways under the edges of the wound.
Wow. So visible bone or muscle, clearly very severe damage.
Precisely. That's grade 4. And then there's one more category.
Which is?
Unstageable. This is when you have full-thickness tissue loss, so you know it's at least a grade 3 or 4. But the actual depth, the base of the wound, is completely obscured by slough or Escher.
Ah, so like a wound with a thick black scab or maybe yellow gunk covering the whole base.
Exactly. You just can't see how deep it goes until that dead tissue is removed, usually through debridement, so you call it unstageable.
That staging system is really clear and obviously vital for understanding the extent of the damage. Beyond just the stage, though, what else do we need to assess about an ulcer?
Oh, a lot. Assessment needs to be comprehensive. You need to look at the likely cause. Was it pressure, shear, friction, the exact location often over bony prominences like the sacrum, heels, hips, elbows, ankles, even the back of the head.
Yeah.
You need to measure the dimensions, length, width, depth. Assess the amount and type of exudate or drainage. Critically, look for signs of infection. Assess the patient's pain level. Note the overall appearance of the wound bed and the surrounding skin, and check carefully for undermining or tracking those extensions under the skin edge. And any odor. It's not just about the hole, it's the whole picture, including the patient context.
Got it. A really thorough assessment is key. So how do we investigate both the ulcers themselves and the patient's risk?
Well, investigation really starts with that thorough clinical assessment we just talked about, looking, measuring, describing. That's number 1. For specific tests,
Yes.
wound swab cultures are mentioned, but the guidance is very clear. They are not routine.
Right, I remember that.
Ulcers are almost always colonized with bacteria, meaning bacteria are present, but not necessarily causing an infection. You only send a swab if there are clear clinical signs of infection, like increased redness, warmth, pus, or the patient seems unwell.
That's a classic MSRA point, isn't it? Don't swab routinely.
Exactly. Nail that one down. Blood tests can be useful, though. They give important context, looking at nutrition markers like albumin, maybe inflammatory markers like CRP or white cells if infection is suspected, or just checking overall health like kidney function or a full blood count.
And imaging.
Imaging like x-rays or sometimes an MRI might be needed, but usually only if you suspect the ulcer has gone really deep and might be involving the bone osteomyelitis or if you suspect a deep abscess collection.
Okay. And this brings us back to the Waterlow score, right? You mentioned we'd cover it here.
Yes, the Waterlow score. It's essentially a structured way to assess a patient's risk of developing a pressure ulcer. You calculate a score based on a number of factors.
What kind of factors?
Things like gender, age, build, or BMI, the type of skin, mobility level, continence, recent weight loss, nutritional status, underlying medical conditions, even medications.
So you plug in all those patient details and get a score.
Pretty much, yes. And the score then guides the risk level. Generally, 0-9 is considered little risk, 10-14 is at risk, 15-19 is high risk, and a score of 20 or above is very high risk.
And when should this be done?
The recommendation is often to do it within about 4 hours of a patient being admitted to hospital, for example. But remember, it's always an adjunct to your clinical judgment, not a substitute for it. It helps flag patients, but you still need to use your clinical skills.
Okay, let's try that scenario again. You assess that new patient admitted with pneumonia, 85 years old, underweight, BMI 17, mainly bedbound due to weakness, needs help with continence. Using the Waterlow categories, would you classify their risk as low, at risk, high, or very high?
Oh, absolutely high, most likely pushing into very high risk. You've got advanced age, immobility, low BMI, suggesting malnutrition risk, and incontinence. Those are multiple significant risk factors all stacking up. That Waterlow score would almost certainly be 15 or well above.
That makes total sense. It really confirms why that patient needs immediate attention for prevention. Okay, let's move on to perhaps the most crucial part, managing these ulcers once they've formed, and even more importantly, how do we prevent them in the first place?
Right. The core goals of management are, well, relatively simple to state, but often complex to actually achieve. You need to relieve the pressure, optimize the wound environment itself, address all those underlying risk factors we hammered home earlier, and promote the patient's overall health and healing capacity.
Sounds like it needs a team effort.
Absolutely. It really requires a multidisciplinary approach. Nursing staff, doctors, dietitians, physiotherapists, occupational therapists, and sometimes, for severe non-healing cases, surgeons might get involved.
So what are the specific treatment strategies once an ulcer has actually formed?
Key strategies really revolve around regular repositioning, literally taking the pressure off the affected area, using specialized support surfaces, things like pressure-relieving mattresses or cushions, meticulous wound care,
What does that involve?
gentle cleaning, selecting the right type of dressing based on the wound characteristics like how much exudate there is, whether there's dead tissue. Ensuring adequate nutrition and hydration is vital, especially protein and certain vitamins for healing. Managing any pain the patient has. And of course, controlling infection if it occurs.
And infection control, you mentioned not using antibiotics routinely, so when are they used?
Good point. Topical antiseptics or antibiotics directly on the wound are generally not recommended routinely because, as we said, ulcers are often colonized. Systemic antibiotics tablets or IV are reserved for when there are clear signs of spreading infection, like cellulitis, or systemic illness like sepsis.
What about barrier creams?
Barrier creams are useful for protecting the surrounding skin, especially if there's incontinence, but they don't treat the ulcer itself.
And debridement, removing that dead tissue, the slough or eschar.
Yes, debridement is often really essential, especially for those unstageable ulcers or ones with a lot of dead tissue preventing healing. It can be done in different ways. Sometimes certain dressings help break down the tissue chemically, that's autolytic debridement. Or it can be done surgically by a clinician with forceps and a scalpel.
Surgical debridement sounds quite involved.
It can be. And surgical intervention, like flap surgery to close a large defect, is usually reserved for severe chronic ulcers that won't heal otherwise, and it carries its own risks, like infection or the surgery failing.
Right. So prevention really seems like the much better route, if at all possible. What are the key prevention strategies?
Prevention directly targets those risk factors we identified. So regular repositioning is paramount, turning a bedbound patient frequently, maybe every 2 hours, helping chair-bound patients shift their weight regularly.
Okay.
Using appropriate pressure-relieving devices, special mattresses, cushions, heel protectors, daily skin inspection, especially over bony areas, to catch any grade 1 changes early.
Crucial.
Promoting good nutrition and hydration. Encouraging smoking cessation. Careful moisture management, keeping skin clean and dry. Using barrier products appropriately if there's incontinence. Also using emollients to keep skin healthy. Considering specialized mattresses for those identified as high risk, sometimes even things like medical-grade sheepskins. Or using polyurethane foam dressings on areas prone to high friction, like heels.
And educating patients and their caregivers must be a huge part of that.
Absolutely vital. They're often the ones doing the day-to-day care and monitoring. It's interesting that the source material does mention that the evidence for the impact of having dedicated wound care teams specifically on prevention is a bit unclear, suggesting perhaps that getting the fundamentals of good basic nursing care right for everyone might be the most critical factor.
That's an interesting point. Okay, let's think about our high-risk patient again, the elderly, underweight, bedbound, incontinent patient with pneumonia. What would be the first few prevention strategies you'd want to see initiated immediately based on everything we've discussed?
Okay, first steps for them. Immediate risk assessment, probably confirming that high Waterlow score. Then straight onto implementing a regular turning schedule, say 2 hourly turns if they're fully bedbound.
Right.
Providing an appropriate pressure-relieving mattress immediately. Starting daily, systematic head-to-toe skin inspection. Paying close attention to heels, sacrum, hips, elbows. Ensuring they have adequate fluid intake and initiating nutritional support, maybe involving a dietitian. And definitely using appropriate barrier creams or products due to their incontinence. Plus, obviously, treating their pneumonia and working on their mobility is feasible, as those are underlying risk factors too.
Those practical steps really bring it to life. So what's the general outlook, the prognosis for patients who do develop pressure ulcers?
Well, it varies hugely. It really depends on many factors. The stage and severity of the ulcer when it's found, the patient's overall health status, their nutritional state, and critically, the quality and timeliness of the care they receive.
So an early stage ulcer on an otherwise relatively healthy person.
Much, much better prognosis. Early detection, prompt intervention, and comprehensive care significantly improve the chances of healing, sometimes quite quickly for grade 1 or 2.
But the more severe ones.
Yeah, severe ulcers, especially grades 3 and 4, are much harder to heal. They can easily become chronic, non-healing wounds, and they significantly increase the risk of serious complications, and sadly, can even contribute to mortality, particularly in frail or very ill individuals.
Which brings us neatly to those potential complications. What are the real downsides, the worst-case scenarios we need to be aware of?
The complications can be really serious. Locally, you can get infection within the ulcer itself, which can spread to the surrounding skin and soft tissues. That's cellulitis. It can form an abscess, a collection of pus, or if it goes deep enough, it can infect the underlying bone osteomyelitis.
And systemically.
More dangerously, the infection can get into the bloodstream, leading to sepsis, which is, of course, a life-threatening medical emergency. Beyond infection, ulcers can lead to significantly delayed healing, become chronic wounds that persist for months or years, cause substantial scarring, and sometimes lead to contractures that restrict movement if they're near a joint. And we shouldn't forget the significant psychological distress, pain, and reduced quality of life for the patient.
Sepsis really sounds like the most urgent and life-threatening concern there. What are the specific red flags for a serious infection developing from a pressure ulcer that demand immediate action?
Yeah, knowing these is critical. Key signs to watch for include spreading redness, warmth, and swelling around the ulcer site, new or increased pus discharge from the wound, the patient developing clammy or cold skin along with a fast heart rate. Those could be signs of shock developing from sepsis.
Okay.
Severe or rapidly worsening pain at the ulcer site, which might indicate a deep infection or abscess, and of course a high temperature or fever.
Okay, final scenario. Our elderly patient who was high risk unfortunately developed a grade 2 ulcer on their heel despite preventative measures. Now, a few days later, they develop a fever, seem newly confused, and their heart rate is 120. What's your immediate concern?
Sepsis, absolutely. Fever, new confusion, and tachycardia in a patient with a pressure ulcer. Those are major red flags, screaming systemic infection. That situation requires urgent medical assessment, blood tests including blood cultures, probably lactate, and likely prompt initiation of broad-spectrum systemic antibiotics while waiting for results. You can't delay.
That really reinforces the importance of recognizing those danger signs. Okay, so we've covered a lot of ground. The what, why, who, how they develop, how to assess and stage them, how to manage and prevent, the general outlook, and the potential dangers.
It really is a topic that brings together so many different aspects of patient care, doesn't it? From fundamental nursing care like turning and skin checks, right through to complex medical management of complications. Understanding the why, the pathophysiology, and risk factors truly underpins effective prevention. And prevention is always better than cure here.
Absolutely. So what does this all boil down to for you preparing for the MSRA? It means being able to confidently define a pressure ulcer, rattle off the major risk factors, and maybe group them. Understand that EPUAP staging system cold, or grades 1 to 4 plus unstageable. Know when not to send that wound swab.
Definitely.
Be able to interpret a Waterlow score and understand its place, and outline the key strategies for both prevention and management, including, crucially, recognizing those critical signs of serious infection like sepsis. These are really high-yield areas because they reflect common clinical scenarios and fundamental principles of patient safety and care.
Exactly right. It's not just about memorizing lists. It's about being able to think through a patient scenario and apply these principles effectively. That's what matters.
Spot on. And perhaps a final thought to leave you with. Given that we know pressure ulcers are largely preventable and we know their treatment is incredibly costly, both financially and in terms of human suffering, what systemic changes or priorities might we need to shift within healthcare systems, maybe globally, to truly make a significant dent in their incidence? It remains a persistent challenge, even though we've known how to prevent them for decades. Something to ponder. For more free MSRA revision resources, remember to visit freemsra.com. And for the full premium revision toolkit, you can head over to passthemsra.com. Thanks so much for joining us for this deep dive. Keep learning, keep thinking critically, and we'll catch you next time.